Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Japan, Professor Yoshitaka Nagashima. Prof. Nagashima is an assistant professor at the Nagoya University Hospital, Japan. He is an accomplished spine surgeon, neurosurgeon, and researcher with a focus on innovative glioma research, minimally invasive spine surgery, and neurotrauma research. In addition to board certification in neurosurgery, he is also a certified spine surgery instructor from the Neurospinal Society of Japan, certified spinal surgeon from the Specialty Board of Japan. He has published several articles in various leading peer-reviewed journals, and he has also won several awards and honors for his outstanding contribution to research in Japan. We are extremely honored to have him today at our webinars, and today he'll be talking about extramedullary spinal tumors. The speaker for the second session of today is our honored guest from Hong Kong, China, Professor Calvin Mark, Dr. Calvin Mack. Dr. Calvin is a consultant neurosurgeon at the Queen Elizabeth Hospital, Hong Kong. He is also a clinical associate professor in the Department of Neurosurgery, the Chinese University of Hong Kong. He is the secretary of the Hong Kong Neurosurgical Society and the first vice president of the Hong Kong Neuro-Oncological Society. He is a noted author with several publications in various peer journals. He is also an invited faculty to various workshops and conferences. We are extremely grateful to him for accepting our invitation to be a speaker for today's webinars, and today he will be sharing his experience of 60 cases of transorbital surgery. The chair for the first session of today's webinar is our honored guest from Chile, Prof. Felipe Valdivia. Prof. Valdivia is a consultant neurosurgeon and chairman at the Clínica Almena de Santiago, Chile. He is an expert in the management of spinal tumors and spinal neurotrauma. We are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honored guest from Gangnam, Korea, Prof. Hunho Park. Prof. Park is Chief of Neuro-Oncology Center at the Gangnam Severance Hospital, Skull-Base and Neuro-Oncology Clinic, Yonsei University, Korea. He is a member of the Society for Neuro-Oncology, Korean Neurosurgical Society, and Korean Brain Tumor Society. He is also a noted author with several publications in various peer-reviewed journals, and he has also been decorated with several awards and honors for his contribution to research in neurosurgery. We are extremely grateful to him for accepting our invitation to chair the session of Dr. Calvin Mark. On behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to all our colleagues in China, and we are extremely grateful to Prof. Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Bun Seng and Dr. Hui Pham from Malaysia and Dr. Hui Pham from Vietnam are my co-hosts for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Felipe Valdivia.
Today, in this section of the webinar, Professor Yoshitaka Nagachami, neurosurgeon at Nagoya University Hospital, will do a presentation. He will present extramedullary spinal tumor, analyzing their general characteristics and emphasizing aspects of his surgical techniques. Professor Nagashima has developed applied research in spinal tumor with several publications in recognized journals, making him a leading specialist in this field. Certainly, advancing imaging and surgical techniques made it a challenge to achieve better functional outcome for our patient. I think that is the most important aspect for this topic. Thank you, Professor Nagachami, for this opportunity to discuss this topic.
Good evening, everyone. It is a great honor to speak at this ACNS webinar. I would like to thank Professor Yoko Kato, the organizing committee, and especially Dr. Roger and Professor Philip Barbier for the kind invitation and warm support. Today, I will be talking about extramedullary spinal tumors, a topic that continue to present both diagnostics and surgical challenges. I hope this lecture will provide some useful insights based on our clinical experience and recent advancements. In the classification of the spinal tumors, based on the anatomical site of the origin, spinal tumors are classified into three categories: intradural extramedullary tumors, intramedullary tumors, and extradural tumors. This is the etiology of the extramedullary tumors. 40 to 45% in all spinal tumors. Annual incidence of is 0.4 to 10 per 100,000 people. Mean age is 46 to 52 years. Male predominance, but a female predominance in meningiomas. Thoracic region is more prevalent, and approximately 50% are located posterior to the spinal cord. There is regional variations. In Asia, a higher prevalence of nerve cyst tumors, including the schwannomas or something. But in North America and Europe, meningiomas are more frequently reported. In extramedullary tumors, there are several types of the tumors. The one is nerve cyst tumors, including schwannomas and neurofibromas. The second one is meningiomas. Nerve cyst tumors and meningiomas account for the majority of intradural extramedullary tumors. And other types of tumors, including mixed papillary ependymoma, dermoid and epidermoid tumors, endodermal cyst, and metastatic tumors. Okay, now we talk about nerve cyst tumors. This slide is written in Japanese, but it is useful to show the schwannomas and neurofibromas. From an anatomical perspective, the small left functional unit of normal peripheral nerve consists of the axon and its surrounding schwannoma cell. This is a schwannoma cell and axon. And these units are banded and further lapped by perineural cells to form fascicle. It is a red one here, located here. And peripheral nerve typically consists of multiple fascicles, and tumor often arise from these structures components. In fact, many peripheral nerve cyst tumors originate from these fascicular units and are encapsulated by the perineurium. In the schwannomas, they are benign tumors that arise from Schwann cell, only Schwann cells. Therefore, they grow eccentrically from the nerve, moving the nerve fibers rather than inflating them. So this is a schema B. The tumor is pushing away the other nerves. So therefore, they grow and the parent nerve is preserved. On the other hand, neurofibromas grow from a variety of cells. Therefore, they tend to arise in the center of the nerve and affect the entire section of the nerve, causing it to expand in spindle shape or diffuse manner, as shown in the figure C. So in the schwannomas, this slide shows the actual method of the extradural tumor resection. We begin by incising the tumor capsule from an area where there are normal nerve fibers. Then, by carefully dissecting the tumor within the capsule, we can identify the proximal and distal portion of the originating nerve. By cutting the nerve at this point, we are able to achieve complete total tumor removal within the capsules. The lower left image shows the actual surgical fields. As you can see, by staying with the capsule during this section, we can safely remove the tumors without injuring critical surrounding structures, such as the vertebral artery or other nerves. Okay, now let's show you, sorry, this is the various locations of schwannoma development. And the schwannoma is, of course, that sometimes located in the intradural part, but sometimes intradural and extradural type, and the pure extradural type. And in very rare case, the tumor exists intramedullary type. And this is the classification of the dumbbell type tumors, including schwannomas. When classification the dumbbell-shaped tumors, including schwannomas, the most widely used system is Eden's classification. This system is categorized tumors based on whether they extend across anatomical boundaries, such as the intradural space, the extradural space within the spinal canal, and the parasitical region. In addition to ACNS classification, more detailed subclassifications are sometimes used, particularly those that assist in determining the optimal surgical approach. But this ACNS classification is the most common classification for the dumbbell type tumors. Okay, now we show the some surgical cases and surgical videos. This is a 70s female presented with sensory disturbance in the left upper limbs. And what I showed that intradural tumors left posterior side of the spinal cord. This is the surgical video. The right side is cranial and the left side is caudal. After opening the dura, we dissect the tumors from the spinal cord. This tumor is not so adherent to the spinal cord, so we remove the tumor total removal. We cut the originated root, and then we cut another originated root. And finally, we accomplished the total resection of the tumors. This is an easy case. And the next is a more complicated case, C1 dumbbell schwannomas. These are MRI-T2 weighted and gadolinium-enhanced T1 weighted images. The tumor exists intradural and extradural part. Intradural portion of tumor is located anterolaterally on the left side of the spinal cord and brainstem. At the extradural, the tumor is located between the vertebral artery and posterior arch. So we plan that tumor removal using transcondylar force approach for the intradural part and removal over C1 posterior arch.
Plan to tumor resection using transcondylar.
Wow. Okay, this is 3D images by fusion images, MRI and CT angiography. Here you can see that the extradural part of the tumor is compressing between the vertebral artery and C1 posterior arch. So after removing the C1 posterior arch laterally enough, we can remove the tumors from the caudal side. And intradural part, the tumor is in front of the spinal cord and the brainstem. So we need to the axis using the transcondylar force approach, so-called the parallel approach. So this is the surgical video.
The patient is pressed from position. We made hockey stick skin incision. Then we dissected the muscle and exposed the bone. The occipital bone was removed. Then we performed a resection of the C1 posterior arch. After removing a block of the bone, we proceeded to remove the bone more laterally. This procedure created a large working space in the extradural space. After that, lateral aspect of the foramen magnum was removed until the condyle was confirmed. This is a picture of the bone removal being completed. We used the Doppler to check the position of the vertebral artery. This is the vertebral artery running like this. Then we cut the tumor capsule and started to tumor removal. Intraoperative findings are schwannomas, so we performed intracapsular resection and removed the tumor piece by piece. And then we were able to remove the most part of the tumor of the extradural space. After that, intradural tumor was rejected. The tumor was also removed piece by piece. Fortunately, the tumor was not adherent so much. So we were able to pull out the tumor in front of the spinal cord as well. The tumor mass was cut and removed. After that, there was a small amount of tumor remaining between the dural matter. But if we removed it, we would be difficult to reconstruction. So we decided to just coagulate it and left behind it. And then we were able to remove almost all of the tumors. The post-operative MRI weighted image confirmed that the tumor has been successfully removed. CT images showed that the occipital bone and the posterior arch of the C1 were well removed. A mild accessory non-palsy developed postoperatively but improved within approximately 2 months. The post-operative MRI weighted image confirmed that the tumor has been successfully removed. CT images showed that the occipital bone and the posterior arch of the C1 were well removed. A mild accessory non-palsy developed.
And this is the next case, spinal neurofibroma case. This is a teenager boy, a neurofibromatosis type 1. The patient is presented the gradual progression of the upper and lower extremity muscle weakness for the past 6 months. MRI showed epidural tumors and spinal cord compression at bilaterally C1-2 level. Tumors not contrasted with gadolinium-enhanced MRI. Interestingly, cervical X-ray reveals that AAD, therefore, tumor resection and OM navigate guided C1-2 fixation were planned for this patient. This is the surgical video. The difference was placed on the C2 spinal process, and then we started to the removal tumors. At this stage, we think that the tumor is a schwannoma, but finally we found that the tumor is neurofibromas. So we removed all of the tumors. Then we export the C1 lateral mass, and we inserted the C1 lateral mass screw only using the OM navigation systems. We make a pilot fold with stealth midas, then inserted C1 lateral mass screws. Next, the C2 pedicle screw was inserted. A pilot hole was created with stealth midas. Then, screw length was calculated. And finally, C2 pedicle screw was precisely placed. Post-operatively, a total removal tumors was achieved, and pathological findings were neurofibromas. Muscle weakness improved, and the patient was able to walk at 3 months post-operatively. C1 and C2 screws are in the correct position. And I want to share the rare type of the nerve cyst tumors. It's called the MPNST, malignant peripheral nerve cyst tumors. MPNST accounts for approximately 5% cases and over 50% are associated with NF1. Preoperative diagnosis is achieved by FDG PET and biopsy. Wide en-bloc resection, including surrounding tissues with pre- and postoperative chemotherapy, is required. So now I want to share the case of 40 female with NF1 cases. This is an MRI. SDIR image shows that S1 schwannomas, nerve cyst tumors, enlarges within 6 months, and FDG PET shows the SB max is 11.1. So we suspected that the patient has an MPNST. So we performed the tumor biopsy, open biopsy, by using OM navigation. We check the point of the tumors, and we can see where the tumor is located. And then we drill the tumors. During the surgery, the tumor looks like the normal schwannomas. So we cut the tumor capsule. And then we take the tumor species for the diagnosis. Postoperative diagnosis was MPNSTs. We discussed the orthopedic surgeons, and the tumor is difficult to the en bloc dissection. So the patient is only take radiotherapy, which is only the palliative therapy. Next, I want to talk about meningiomas. Meningiomas is spinal original tumors account for about 10% overall, with 80% occurring in the thoracic spine. They are more common in the middle-aged women. They often occur the anterolateral to the posterior lateral aspect of the spinal cord. In NF2 cases, multiple regions sometimes occurred. On MRI, T1 hypointense to isointense, T2 hyperintense, and homogeneous enhancement. Calcification is often observed and is useful for differential diagnosis. The treatment of choice is complete surgical resection, aiming for Simpson grade 1 or 2. The recurrence rate after total or near total resection is reported to be 3 to 7%. In cases of subtotal resection or recurrence, radiotherapy could be considered. This is a meta-analysis of the relationship between Simpson grade and recurrence in spinal meningiomas. In total, 950 cases, the prognosis of the Simpson grade 1 and grade 2 is almost the same. So in the spinal meningiomas, Simpson grade 2 is enough for the treatment. Now I will show you the one case of the meningiomas. This is the 60th female presenting with left upper limbs sensory disturbance. MRI shows that right side extramedullary tumors. So in this case, we performing the tumor resection by using the hemilaminectomies. And after opening the dura, we can see the extramedullary tumors. First, we coagulate and devascularization of the meningiomas. This is a key step of the resection of the meningiomas. Then we resect the tumors piece by piece. And finally, we accomplish the total resection of the tumors. Now, I want to share you the SFT, solitary fibrous tumors. SFT is a tumor that is very similar to meningiomas in terms of imaging, and it is difficult to distinguish before the surgeries. SFT has a risk of recurrence, so this has a significant impact on the postoperative response. For this reason, long-term follow-up is necessary if the case is SFTs. Postoperative radiotherapy should also be considered for the remnant tumors. We experience the two types of the small solitary fibrous tumors as shown in the slide. Now I want to share the other type of tumors. This is the mixed papillary ependymomas, WHO grade 2. This is the subtypes of the ependymoma arising from the conus medullaris or film terminalia, often adherent to the caudal equina, making complete resection difficult. Postoperative radiotherapy could be considered. Local recurrence over dissemination may occur in the mixed papillary ependymomas, so careful follow-up is required. We experienced a case with postoperative dissemination of the mixed papillary ependymomas. And this is a surgical video. We began by incising the cystic compartment located on the cranial side, showing the arrowhead in the MRI. After opening the arachnoid membrane, we proceeded with internal decompression of the tumors. The tumor itself was soft and prone to the bleeding. Once mass was sufficiently reduced, we carefully dissected tumors from the surrounding tissues. At this stage, we paid close attention to avoid any specimen of the tumor's contents into the surgical field. We dissect the tumor as extensively as possible, with careful inspection to ensure that no residual tumor tissue remained. And next is epidermal tumors. Epidermal tumors are often congenital with a predilectly for the lumbocervical region, frequently associated with the spina bifida and abdominal sinus. Acquired case can occur due to the inadvertent implantation of the epidermal elements, including the following lumbar punctures. Maximal self-rejection should be aimed to prevent recurrence. So we experienced a case developed following the lumbar punctures. And this is the surgical videos. This case, the patient had the tunnel of cyst at the caudal side, but we fastly removed the tumors. Epidermal tumors is easily to recurrence, so we carefully removed the tumors. And this is almost a final view. A lot of the almost of the tumors are rejected. And then this case was treated for the tunnel of cyst, punctured cyst, cut the membrane, and just sutured. Okay. The last one is endodermal cyst. Unfortunately, we haven't the surgical video, but I want to share the contents. The cysts are formed from the remnant of the neurolytic canal during fetal development, often accompanied by other anomalies. Most commonly found in the thoracic spine, about 40%, followed by the cervical spine. But it dominantly occurs in the anterior subarachnoid space of the spinal cord, most common in individuals in their teens or to 20s. If the capsule is left behind, there is a high risk of the recurrence. This is the image of the endodermal cyst. This is a reference of today's lectures. Thank you for attention. My presentation is finished.
Thank you very much, Dr. Nagachima, for really so nice presentation.
Thank you.
We have some question in relation to the technical aspect. First, what do you think about in relation to use the neurophysiological monitoring in this surgery? It's a nice technology, but you know it's not so easy for each hospital to will do that. What do you think about?
Your comment is about the MEP monitoring, or?
It's for the neurophysiology monitoring. That's meaning somatosensory potential evocate, motor evocate, and stimulate.
Okay, I understand.
Yeah.
Thank you for the point. Good point. In all cases, we use MEP monitoring and SEP monitorings. Almost of the spinal tumor is benign, so we don't have to total removal of the tumors. So if the MEP is decreased, we can choice of the stop the procedures.
Okay.
So the monitoring is vital for the patient.
Okay. Other aspects in relation to the technical aspect for this surgery is to ask you in relation to what is your thinking in relation to prevent the fistula? I think in this surgery, the most frequent complication is the fistula of cephalorachid liquid. That's it's a big problem. What do you think about?
What do you mean with the fistula?
Yes, to prevent the fistula in the surgery. That's meaning do you use microsurgery suture of the dura mater?
Dura mater. It's a important point, and we suture the dura maters, and after that we use Duragen or something, and we prevent the CSF leak after the surgeries. And in the many tumors, I showed that Simpson grade 1 and grade 2 is the same prognosis. So we don't have to remove the dura maters. I think that almost all of the case was just coagulated for the many tumors. And we can easily suture the dura maters.
Okay. And at this time, in our hospital and in our country, we have a big discussion in relation, of course, with some specialists for orthopedics or trauma in relation to use arthrodesis in this case. Some people said in all cases you need to put some arthrodesis because you need to prevent the deformation after or something. But really, if you see the evidence, the medical evidence that this is a big challenge to answer the question. What do you think about?
Sorry about
the question is, what do you check about to use the arthrodesis?
Arthrodesis?
Yes, to put some screw in the spine.
Fixation after surgery.
Fixation.
Okay. Okay, I understand. So some patients that get the alignment is get worsening, and some patients got the kyphotic changes. Yeah. I think that we are the neurosurgeons, so we can use the microscope very well. So we make just the small corridors using the small corridors, and we remove the tumor piece by piece, and we don't have to the another fixation a lot of cases. But some cases, of course, we that we need to the drill the facet joint or something. At that time, we use screw fixations.
Okay.
Mhm.
Okay.
Dr. Raja?
Yes, if there are any questions from the house, we can take them now. Yes, Hoi, any questions from you?
Not yet. Thank you.
Fine. So I'll ask a few questions, Prof. Nagashima.
Yeah.
What about the extent of laminectomy? Do you do a full laminectomy or a hemilaminectomy?
Okay, so it depends on the site of the tumors. I think that if the facet joint is intact, the hemilaminectomy or laminectomy is not a problem. But if you need to remove the facet joint, we have to choose the posterior fusion.
Okay, that's wonderful. And regarding what Prof. Valdivia asked, I would like to continue with that fixation part. Usually in thoracic dumbbell tumors, when you take out the facets, you do not fix them as there is support from the ribs. But in lumbar, ideally, if you take recommendations may vary. Some people may advocate fixation when you take out a lumbar facet for removal, for removal of a dumbbell tumor. But once Professor Nicolae Convolou from Burdenko was here as a speaker, and they never fix any facet after lumbar laminectomy and facetectomy. They have more than 3,000 cases of spinal tumors in their review, and this is their principle. So they think that it is not really necessary. And have you evaluated the functional outcome in your cases with respect to tumor occupancy ratio?
I think that I showed that the intracapsular tumor resection. This approach is very good because the surrounding nerve root is intact because we manipulate only the inside of the tumor capsule. So I think that our outcome is good.
Right. I was asking about the tumor occupancy ratio, like when the ratio of the tumor to that of spinal canal. It's divided into 25 to 50, more than 50 to 75, and more than 75. So the more that tumor occupies the spinal canal, there is a trend towards bad outcome. But certainly not the case in several extradural spinal tumors. But you have it in intramedullary, IDEM tumors. So if there are any further questions, Ben Chinsai, thank you for joining us from Taipei. Would you like to ask something?
Yes, and thank you so much for your presentation. So I would like to ask about very short question. I would like to ask about your opinion about the recurrent meningioma after the radial surgery in the spine. So what is your opinion of doing the surgery again versus or is there any other newest updated treatment or systemic treatment for this type of difficult tumor?
Yeah, thank you for the question. This is a difficult question, but for the spine surgeon, we have to preserve the function. If that patient can recover by removing something of the meningiomas, recurrent meningiomas, we do the another surgeries for the decompression of the spinal cord, and then we consider the other therapy, chemotherapy, and radiation therapies. This is my opinion.
Okay. Thank you so much.
Thank you very much, Ben. Are there any questions? I can see Petra-san. Petra, would you like to ask something?
Not yet, Raj. Thank you.
Okay, Petra. Thanks for joining. So we will close this session with the final remarks from Professor Valdivia.
Thanks for your nice presentation. Really, one of the most important aspects, almost spine tumor are benign. So the principal goal is to take all the tumor, and the function of the patient. I think at this time the most important tool for that is the surgery. So we need to develop more and more techniques for complete the goal. That is the most important aspect. Really, we have a big challenge with the patient. Do you find a little tumor, no symptom, to take the decision for the time of operate? But it's a very nice presentation and to motivate to develop more and more our specialization. Thanks.
Thank you so much.
Well, thank you, Prof. Nagashima and Prof. Valdivia. It was indeed a very interesting session, and we are extremely grateful to you both for taking out your time to support the educational initiatives of the ACNS. Thank you very much. So, if you both would like to continue for the second session, you're more than welcome. So, I'll move on to the second part, and I will invite Prof. Hunho Park from Korea for a short introduction and invite Prof. Calvin for his presentation on transorbital surgery. Prof. Park, all yours.
All right, good evening, everyone. Our next speaker is Dr. Calvin Mack from Hong Kong, Queen Elizabeth Hospital. He's a distinguished, renowned neurosurgeon who has recently made striking progress in the field of endoscopic transorbital surgery. I have personally spent a year working with Dr. Mack in France back in 2018 when we were fellows of Sebastian Froelich at the Lariboisière Hospital in Paris. Dr. Mack is a good and a long-time friend of mine, and today he will be presenting his dedication and hard work on the endoscopic transorbital surgery, its indications, and he will be specifically sharing his expertise in the field with the vast 60 cases he has done so far. So I'll be handing over the mic to Calvin, please.
Thank you, Professor Park, Hunho, which I'd like to call you as usual. So thank you very much, Raja, for the kind invitation, and thank you, Professor Xu Bin, for the warm invitation from China as well, and of course, Professor Kato for giving me this opportunity again to share my experience and to involve in education in the ACNS platform. So I'd like to start my lecture today. It will be sharing my experience after having done 60 cases of endoscopic transorbital surgery in Hong Kong Queen Elizabeth Hospital. So a little bit about my hospital in Hong Kong. It's a Queen Elizabeth Hospital. It's the oldest and largest neurosurgery department in Hong Kong for over 60 years of history now. And it's a we also have a neurosurgery simulation and microsurgical laboratory. We currently have 5 stations, and we're planning to expand it as well. So if young and enthusiastic trainees and neurosurgeons want to come to Hong Kong to learn about skull base and endoscopic work, so feel free to join as well with us. So before I start, I'd like to advertise again about Hong Kong, not only about the good food and all the sceneries, but we're also hosting the 2nd annual meeting of Endoscopic Transorbital Society in Hong Kong in November 2025, 14 to 15, and it will be in conjunction with the Hong Kong Neurosurgical Society annual scientific meeting on skull-base surgery as well, which would be Friday to Sunday. If you're interested, you can pre-register on this Google form or visit the Endoscopic Transorbital Society website, and with the details will be available in due course this month. So back to the topic today, I'd like to start with a case. It's an old lady with a right eye proptosis, 82-year-old lady with history of carcinoma and developed 2-month rapid progressing right proptosis, ptosis, and diplopia, which with this scan here showing there's a contrast enhancing mass at the right cavernous sinus. It's actually encasing the carotid artery, and you see that this lady is quite old, so but she's symptomatic and progressive. So what would you like to do? Of course, we'd like to do something less invasive. We did a PET scan in view of history of carcinoma, which is equifocal. Tumor markers negative and prolactin level is marginally high. So there are 5 options that I can think of: radiotherapy, craniotomy, endonasal, transorbital, or conservative in view of old age. So because this is not a live course, so I cannot ask you to vote, but just give the answers, keep the answers with yourself. So to neurosurgeons, Orbit is actually a window to the skull base. Now, neurosurgeons are quite familiar with Orbit, but usually via the open skull base approach, for example, FDOZ approaches or other open orbitotomy approaches. Now, we view it from anterior side. This is something that can actually use as a window to the skull base. So think about it, just posterior to the orbit, we have the anterior cranial fossa, middle cranial fossa. Inferior to it is the infratemporal and also the pterygopalatine fossae. Medial would be the paranasal sinuses, frontal sinus, ethmoid, and sphenoid sinuses, and laterally would be the temporalis muscle in the temporal fossa. So we think about the approaches. Now, this is a schematic diagram of the cavernous sinus and neurovascular structures there. The yellow arrow is the craniotomy approach, which is actually a posterolateral approach with regards to the optic nerves and also the cavernous sinus. It is quite a versatile approach. Of course, it is because it's an open approach. However, it is invasive, and it would be not really able to reach the blind spot that is medial and also very deep at the cavernous sinus. Now, of course, we have the endoscopic endonasal approach with the green arrow here. It is a good minimal access approach of the medial compartment to the medial compartment of the cavernous sinus. However, it is not really minimal invasive given the trauma to the nasal mucosa and also the risk of CSF leak. And also, if we want to reach to the lateral compartment of the cavernous sinus, or lesions at the cavernous sinus, but reaching, extending to lateral compartment, oftentimes we need to do a transpterygoid approach, which involves drilling the pterygopalatine fossae and sacrificing the sphenopalatine artery there as well, and then even at times the median nerve will be injured, giving to dry eye symptoms. So this is not a very simple direct approach. Now with this blue arrow here, this is more intuitive. It is a transorbital, and it is good access to the lateral aspect to the cavernous sinus and also the lateral aspect of the orbital apex. So this is a direct and anterior approach. Now we combine the endonasal approach, the green arrow, and also the transorbital approach, the blue arrow here, and it actually covers the whole circle around the orbital apex or the cavernous sinus with the carotid artery as the center of the circle. Now, in these cases, actually combining these two endoscopic approaches in the future, and actually it's happening now. Certain cases, we're actually skipping and do not need the craniotomy approach. Just by endoscopic keyhole approaches or doing bipolar approaches would suffice to certain lesions. Now, if we look in the literature, there will be 2 terms, which to me they're quite interchangeable when you look at the publications. Transorbital approach, endoscopic, that's ETOA. And also the first description is actually by Chris Moe, an American ENT surgeon with a tone. So transorbital neuroendoscopic surgery. Now, if we look into, if we go really deep into the endoscopic transorbital field, now we differentiate it whether or not the orbit is used as a target, which would be the tones, or whether it is just an approach, a corridor to the skull base for neurosurgeons. So this is endoscopic transorbital approach. Now, but in actual fact, we want to study the field of transorbital surgery. So these 2 terms you need to be aware of and look at literature. So as mentioned, it's minimal access and it's more minimally invasive when compared to endonasal. Not only because there's less chance of CSF leak, because in transorbital approach, we do not enter into the paranasal sinuses, and there would be a natural barrier of the post-op swelling of the periorbita up to 7 days post-op, which gives a very good plug to seal off the CSF leak. But also, the cosmetic outcome is much better. And there is no nasal morbidity. So this is I would say, is really minimally invasive and as well minimal access surgery. So this is my little journey of Transorbital. As Professor Park Hoon-Ho mentioned, I started as a fellow in Le Hebrew Hospital in France, and then I did a cadaveric dissection project there, and then I started my first case in 2020. And fast forward, last year reached my landmark 50 and now 60 cases. Happy to share my experience here, and published a book in 2 years ago as well. So for the incisions, so first of all, incisions matters. For neurosurgeons who want to start, I would recommend you start either with the A incision, that is a subbrow incision, or the B incision, which is a lid crease incision. For Caucasians, I think A incision is as good as B because of the deep eye socket. However, for Asians, our eye socket is much shallower, and they may be more concerned about their appearances. So the lid crease incision would be cosmetically more pleasing to the patient. So nowadays, I use the lid crease incision more. Now, for me, I work with a team of experienced oculoplastic surgeons. So I have the privilege to work with the medial corridor, the transcaruncular approaches, and also the inferior transconjunctive approach or the swaying eyelid approaches, etc. However, they're not a must. If you want to do most of your transorbital work with A or B incisions, I think that would be 80 to 90% of times would be fine with the transorbital approach. Now, after the skin incision, there are two ways to handle the orbital rim. The usual way that I do it is actually the left side, the lacrimal keyhole approach, which I learned from the oculoplastic surgeon. So after cutting the orbicularis, we hit the periosteum, and then we strip off the periorbita away from the periosteum, and then we use a drill to flatten the orbital rim instead of removing the whole orbital rim as a free bone flap. This would be cosmetically better to the patient, and we do not need to put back the titanium plate afterwards because there are some patients, they may feel it, they may palpate it. However, if you wish, you can also remove the lateral orbital rim, which is more popular among the endoscopic transorbital world. The only thing is that you need to plate it back afterwards with the two small titanium plates. Of course, there are different ways to plate it, but it's up to the surgeon and the experience and the practice whether or not to remove it or not. After removing or flattening the orbital rim, then we put in the endoscope. Now I use the 4mm endoscope. I use usually initially the 0 degree, and then quickly I switch to the 30-degree endoscope. I find it more comfortable with 30 because I can view more angles without pushing the periorbita a lot. Now, the first structure we need to see is the meningo-orbital band, and then which is the lateralmost aspect of the superior orbital fissure, and then trace it inferiorly, we reach the inferior orbital fissure, and the sandwich between this is the lateral orbital wall, which is a greater wing of sphenoid. By removing the bone here, the greater wing of sphenoid, first of all, we'll reach the temporalis fossa here, the temporal fossa, which houses temporalis muscle. By drilling outwards externally, laterally, we can release the pressure so that we can create some more space, not needing to retract the orbital content that much. And afterwards, we drill directly straight ahead until we reach temporal dura, and by going down inferior, we reach the floor of the middle cranial fossa. So this is a video done by my fellow from Italy last year. So just go through it quickly. So this is a drilling. It's a left side, so I drill towards the lateral aspect first, exposing the temporal fossa, the temporalis muscle. And then here is the temporal dura, the middle fossa dura. We can use a kerosene to punch out the thin bone there. And then we drill the most medial part of the greater sphenoid, which is also termed as the sagittal crest. Now, after removing the sagittal crest, we unlock the meningo-orbital band. And then we cut open the meningo-orbital band. And afterwards, we're going to do an interdural and extradural peeling of the middle fossa dura. And here we expose the cavernous sinus structures. So here is the carotid artery. This is the fourth. This is the V1. Again, this is the V1, this is the V2, this is maxillary strut here, this is the fourth nerve, and this is the third nerve, this is the ACP here, and here is the abducens nerve here, the sixth, and here is the carotid artery. So I did a brief literature review. There are different categories. I'm not going into the details because I'm going to cover it in my lecture afterwards. But essentially, there are major indications include orbital tumors, trigeminal schwannomas, middle fossa, and petroclival, especially meningiomas. CSF leak repair would be good indications, and mesiotemporal lobe tumors, gliomas, which Professor Park has experience in that as well, and other pediatric lesions. So in my center, I've mentioned that most of my cases I use the lid crease incision and also subbrow incision, which there are other incisions which are combined with the ENT or the ophthalmologists. Now, initially, we do a single portal approach for the first 2 years, and afterwards we move to a multiportal applications with the malignant tumors. So basic indications include orbital lesions, including vascular malformations, sphenoid wing lesions like spheno-orbital meningiomas, lateral cavernous sinus lesions, trigeminal schwannomas, and sinus pathologies, for example, mucoceles and CSF leak. Now, this is the first case I want to show you an orbital tumor with endoscopic transorbital removal, presented with RAPD and the drop in the right eye vision. So we use a lid crease incision here, and this is one of the first 10 cases. So I removed the orbital rim. This is published in World Neurosurgery in 2021. And then we drew the greater wing of sphenoid after putting in the 4 millimeter scope. And then here we open up the periorbiter, and then because I want to identify the tumor more readily instead of pulling and loosening the rectus muscle, which can be quite difficult to identify to differentiate between the tumor and the rectus muscle itself. They all look reddish in color. I use the ICG injection. Now, with the ICG injection, the rectus muscle enhances first, and then afterwards, the cavernous hemangioma will enhance afterwards. It's just like in a dynamic MRI sequence. So with this hypoenhancing lesion at the ICG filter with the endoscope, now I can readily identify the cavernous hemangioma. And by doing a dissection around the tumor, I can do an en-bloc removal of the tumor, and even I can identify the stalk of the lesion as well. So it's an en-bloc resection with a post-op clearance of the tumor, and the patient is fine cosmetically and improved in the vision. So this is second case category of middle fossa tumors. This is a recurrent meningioma. For recurrent meningioma, it would be quite difficult to have a good clearance with a transcranial approach, especially spheno-orbital tumor with a hyperostosis and tumor infiltration of the greater wing of sphenoid. That's why we use the transorbital approach. Similarly, we use drill to flatten. This time we flatten the orbital rim instead of removing the orbital rim as a free flap. So this is called lacrimal keyhole approach. So by removing like 4 millimeter area of volume of space, and we can put in a scope and park it there without creating extra space occupying problem to the orbital content. And then this is the mandible retractor that I protect the periorbiter. We need to intermittent release the retractor to prevent extra pressure to the orbital content. This is the hyperostotic bone. I also use the EM navigation to outline the area of the drilling. So use a diamond burr with irrigation to drill, and you can see the tumor intermingled with the hyperostotic bone here. And afterwards, we open up the dura and excise the temporal dura. And then we use for reconstruction, we put in a DuraGen, inlay, onlay, and abdominal fat to seal the dura defect. Post-op, there is no leak, and there is no proptosis afterwards. So next is the peeling of the lateral wall of the cavernous sinus. So this is exactly the same image that we can see in the cadaveric dissection. And this is actually very familiar to most of us to skull-based surgery, because this is actually very similar exposure to the Dolan's approach, although this is a reverse direction. So with this, we can see the again all the cranial nerves here, and the rotundum vali and the anteromedial and the anterolateral triangle. So after opening up the V1 and V2 triangle, we see the abducens nerve, and here is the periclyphal carotid artery. Now, for the cavernous sinus lesion, one of the very good indications would be schwannomas. This is a maxillary nerve V2 schwannoma presented with abducens palsy, diplopia, and V2 numbness. So by splitting the anterior cavernous sinus wall, we remove the sagittal crest, and by doing the blunt dissection, there's actually not much of the venous oozing. There's a little bit, which is controlled by Surgisil. Of course, if you have Flowsil would even be better, but Surgisil usually would be fine as well. And then we open up the anterior capsule of the tumor, and then we do an internal debulking, and we identify the diseased nerve root attached to the tumor capsule of the one of the rootlets of the V2, not the entire nerve, but just the diseased nerve root, and then we identify and cut the small nerve rootlet. And here you see the position of CSF with a microscope. And this is not a big leak, so I just put a DuraGen and some Surgisil for packing, and use a tissue glue without abdominal fat. Post-op, it's a gross-order removal, and post-op there's improved in the abducens palsy and resolved in numbness. We are also able to do an optic nerve decompression and ACP removal with a transorbital technique. So this is a frontal dura, temporal dura, and this is ACP. By removing the ACP using an endoscopic transorbital route for the craniotomy, we can expose the optic nerve, and here's the optic struct, and beneath would be the carotid artery and the abducens nerve. I mean the oculomotor nerve. So this is a case of good case again. This is an orbital metastasis patient with a third nerve palsy and a very, very poor vision. So we decided it would be a good approach to do a minimum invasive yet good clearance of the tumor via endoscopic transorbital. So similarly, we put in a rigid scope here, and we identify the MOB. And then we expose the temporal dura by removing the diseased bone. Actually, the approach, when we do the approach, we're already doing the tumor removal since very beginning. So the surgical time is much shorter than craniotomy. So this is the section of the tumor away from the dura, and this is afterwards we cut the meningeal orbital band. And here we see the optic canal. This is the optic canal, and we do the 270 degree of drilling of the optic canal to decompress. So this is the sector is peeling the bone away from the optic canal, and by doing so, we are able to achieve a good decompression. And the whole clinoid process is infiltrated by tumor, so this is removed. And there's a small mucosa of the sphenoid that we can see from the clinoid process, which we plugged with a fat to prevent CSF leak. So post-op, the patient has improved in the visual acuity from hand movement to 0.3. So remember our patient, right transorbital surgery. We did transorbital removal of the tumor. It is a meningioma with a frozen section. And this is the view inside the cavernous sinus. And we're able to discharge the patient on day 2. So advanced indications include gliomas at the brainstem, and tumors at the brainstem as well, and also multiportal endoscopic approach to handle infratemporal and head and neck tumors there. So this is a case of a recurrent craniopharyngioma. 38-year-old with a multiple transsphenoidal surgery, craniotomy, and gamma knife done as well. Presented with aesthetic gait and recurrence of the cyst into the left pons. So this is subra incision. And we split the anterior cavernous sinus wall. And we're entering the Meckel's cave after incision of the tentorium. Here is the abducens nerve and its ICA and this tumor cyst here after tumor removal by suction. And we're also able to see the facial nerve and the lower cranial nerve complex. It is recently accepted in neurosurgical focus video. If you're interested, you can feel free to go to the video to take a look. And we repair with a DuraGen and afterwards we have abdominal fat graft. So post-op the patient is able to walk unaided, previously wheelchair bound, and now is happy up and about. So between the V2 and V3, we're also able to secure the carotid artery here. It is very important, especially for tumors at this region, especially for malignant tumors. I'm going to skip this invasive pituitary tumor at the infratemporal fossa, but just a short note, this is a good approach for lesions at the lateral part of the cavernous sinus. So we can see the V2 and V3. With a gentle suction, we are able to remove all the tumor at the pituitary, which is a pituitary tumor at the infratemporal fossa. I'll just move forward to the biportal approach that I did with the endoscopic transnasal excision together with a transorbital with a nasopharyngeal carcinoma. So because we need to have a biportal approach to secure the tumor with two approaches, and also at the same time to identify the carotid artery clearly and protected during the dissection. So that's why we also use the transorbital approach. Now this is the V2. And this is the V3. Here is the anterolateral triangle. And by drilling into the foramen rotundum, we're able to identify the carotid artery and also the section tube. So for diseased tumor, it's malignant tumor, so the section tube is excised. And then we do a forehand biportal endoscopic technique with endoscopic transorbital together with the endoscopic transnasal approach. And then we are able to dissect and remove a tumor via the nose with the ICA protected at the transorbital root. This is another case that we did with a triportal excision. It's a sarcoma, malignant tumors. We also use the transoral approach to remove the tumor. This is a 6-centimeter tumor because it's malignant, so we need to remove it en bloc without using a CUSA. It's also accepted in the recent publication and the recent issue of the neurosurgical focus video in April. So for reconstruction, for small dura defect, we use an inlay and onlay typo, DuraGen and tissue glue. Large defect, we add abdominal graft and tissue glue. For biportal, we use a nasal septal flap for reconstruction to prevent infection. We have 2 cases of a retrograde infection. So after using nasal septal flap, it is better. For transconjunctival approach, because the orbital floor is being opened, we need to reconstruct the floor with titanium plate. As mentioned, complications, we do have 2 cases of periorbital infection and a case of arterial bleeding with a meningioma. As bleeding from this branch of M2 patient, we're able to do the hemostasis afterwards. The post-op is fine. There are cases of transient orbital complications, but they usually resolve in 6 to 8 weeks' time. So cosmetically, these patients are doing well in general. This is a book that we summarizes some of our experience. So I'd like to thank my team's experience. I learned a lot from them, ENT and ophthalmologists as well. I believe in collaboration with them, and which enable MIS multiportal surgeries with a tailor-made approach, enable better patient outcome and shorter hospital stay. How to start? Training at cadaveric dissection lab is very essential. So just a final note, this is the Transorbital Society meeting in Hong Kong in November. So if you're interested, feel free to join. Thank you.
Right, thank you for your impeccable presentation on an approach that's getting more and more popular. I know Calvin has put a lot of work and he's really zealous on this approach. Now, I do have a couple of questions to ask. Now, you did mention you do a lacrimal keyhole approach instead of a lateral orbitotomy. Now, in your experience, what's the difference of angle of attack and exposure between doing a lateral orbitotomy and doing a lacrimal keyhole approach?
Yeah, thank you, Hunho, for the question. Now, to me, I think I would say 70% of the cases, just using a lacrimal keyhole will offer the similar angle of attack, especially when we just use the orbit as a corridor. So if we're doing straight inside, so it doesn't really matter a lot. Now, however, if there are lesions at the orbital apex or even at a junction between the middle third and the posterior third of the orbit, I think that removing the orbital rim would be better because the trajectory will be more from lateral to medial. So we need to gain more space there. For lesions at the infratemporal fossa, again, by removing the orbital rim, especially superior parts, that would create more surgical freedom, and that would be better.
Okay, thank you for the answer. My next question would be, I know you do the chopsticks technique, you've learned it from Sebastian. Now, in your opinion, do you think it would be better to use an endoscope holder or insist on doing chopsticks technique? What's your opinion on this?
Now, I think, well, to me, because I'm quite familiar with the chopsticks technique, so that's why I feel comfortable with using it. But recently, I'm exploring ways to change, to be honest, because I want to train more doctors and juniors and seniors alike to perform the surgery. So with the chopstick technique, it's not easy for them to learn to start. So that's why I've been using more scope holders these days. I think it works equally well. However, we need to drill more laterally for the lateral keyhole, or even removing the orbital rim with the endoscopic holder. It's actually a similar concept with the endoscopic endonasal approach. With a single nostril approach, using a chopstick technique is fantastic because you have the walls to lean on and to rotate, etc., and to share the force. However, if we use a scope holder, it's different. So we need to create more space to accommodate more instruments. So using different techniques, I would say, would dictate the incision and also the amount of the bone that I need to remove. But essentially, when we're inside, I think it's more or less similar.
Okay, and my final question would be, during your 60 cases, how would you tell us I know you mentioned in your presentation you never had a CSF leak. In your experience, how can we go about doing this? What's your expertise on this? And how can we avoid an ophthalmological mishap as well during the approach?
It's a very valid question. Well, to be honest, I think I would say I'm lucky not to have a case of a CSF leak. It might come someday, hopefully not so soon, and hopefully not a serious leak. So I'm not going to say it's permanently 0% leak. It never happens to skull-based surgeons who have zero complications. But to be honest, maybe for my patients, they have a lower BMI usually. So they're not obese, and they're usually quite good patients, to be honest. So when I order them to rest in the bed, so they do obey. So I think this would be one of the contributing factors. And for the repair of the leak, I use routinely abdominal fat if it's large defect. Large by means if it's more than an inch of a dural defect, then I put in fat routinely. Concerning ophthalmological complications, I think it's very important to have a good partner to do the retraction, hold the retractor, especially when handling lesions at the orbital apex. Now, if we talk about the, just using the surgical corridor for the transorbital ridge, for example, the tumor is at the sphenoorbital meningioma sphenoid wing or the cavernous sinus, it's okay. So we don't really need to pull. But to be honest, at the orbital apex, we really need to pull a bit on the orbital apex. Now that's difficult. We need to have someone who is experienced, and we need to intermittently release the retractor. And more importantly, we cannot overbend the retractor. Now, it's difficult to show in a webinar, but essentially, if you see my hand here, so this is a strict retractor blade. We just hold it like this, it's a 90-degree, but we do not dig inside. If we dig inside, that would retract and pose a pressure at the ciliary ganglion, which will cause the dilatation of the pupil. And of course, we need to intermittently release the retractor blade, for example, like every 10 and most 15 minutes, if we're really pulling a little bit there, and with the orbital apex lesions, and we need to check the pupils. If pupil is a bit dilated or changing in shape, we need to pause, wait for it to recover, and then before we proceed. And at times, to be honest, there are cases of pupil dilatation, I just need to prematurely stop the surgery earlier, leaving a bit of the tumor. Usually that would be cavernous meningioma there for observation or consideration of radiosurgery afterwards.
All right, thank you, Kelvin. We have a question from the audience. Do you have any experience with NOS for pituitary tumors? Now, you know the pituitary tumors with lateral cavernous sinus wall invasion. Have you ever had any experience or the chance to resect pituitary tumors like that?
Yeah, so we do. So actually, that's a very good approach, I would say, especially for those pituitary tumors or pit nets that are soft. So it's actually usually like extradural. Of course, they're mostly like extra dural at the infratemporal fossa. Or if it's intradural, that would be usually protected by the arachnoid membrane. So that would be a good approach to remove the tumor of the pituitary tumor with a suction. Even there is and also it would be a good way to combine with an endonasal as well. So it's like a biportal excision of these kind of invasive pituitary tumors, especially for those that really extend quite laterally.
Okay. Dr. Ajit?
Yeah, it's a very excellent technique, and I'm really a fan of your technique. Congratulations for popularizing this excellent technique. My question is regarding certain tumors that is rising from the V1, V2. When we trying to excite, it just got a intracranial as well as extracranial extension that may go inside the infratemporal fossa or ptergopalpate fossa through the foramens. When we use this transorbital approach, how will you approach? One question is how will you approach? Another is how will you close prevent the CSF leak, because this is a very large defect.
Yes. Okay. So so the question is for these V1 and V2 schwannomas, if they are like dumbbell, right? That enter intra and extracranial, how do I do it with endoscopic transorbital? Is that the question?
Yes.
Yeah, okay.
Yes.
Sure. So usually for these large tumors, they're actually good cases, to be honest, for endoscopic approaches, because they actually open up the surgical corridor. So we do not really need to do a lot of dissection before we see the tumor. So this is the first point. And I use the usual debulking technique with a microsurgical technique after opening up the capsule and using the windows between the nerve. So between the V1 and V2, that would usually be a good surgical corridor to enter the tumor. And with adequate debulking, it depends on the case. So sometimes if the patient is old or very adherent to the cavity sinus wall, I do not want extra damage to the cavity sinus cranial nerve, so I can leave part of the capsule there behind because it's benign tumor. For the reconstruction, as shown in the presentation, I always put in fat if it's a large defect, abdominal fat graft, and I use inlay and onlay Duragen with a tissue glue to seal off the communication between the dura defect, intracranial compartment, and extracranial compartment.
Suppose it's tumor that erodes the skull base, that's the middle fossa, and if it goes into the pterygopolyteal fossa or infratemporal fossa, there will be a large defect will be there.
Yeah.
Is it enough to use these things or any extra precautions to be used in that?
Yeah, to be honest, unless they enter or intraoperatively you communicate between the with the nasal cavity or the sphenosinus, then there's nothing much to worry because it's a closed space, so you can just fill it in with fat without much problem, and then you just suture the skin and post-op, because there is a periocular swelling, which is very good for the CSF repair. It's like a natural barrier for the first 7 days. If, however, there is communication with the paranasal sinuses, then I would recommend to use a nasal septal flap to reconstruct. But that's usually not necessary. Again, it depends on the pneumatization of the sphenosinus and also the size of the tumor.
Can I ask one more question?
Yeah, sure.
Yeah, that's about the. It's an excellent technique for the petrous apex, that is between the arcuate eminence and the that petrous V3 region. But I have tried 1 or 2 cases, but the difficulty is the extent, because it's the very depth, and the usual instruments won't reach there. And even for the posterior fossa also see same problem of this. How will you overcome this problem? You use a special instruments or you use same instruments?
Yes, a very good question. So for petrous apex tumors, to be honest, I do not think endoscopic transorbital is a first choice for approach. I would rather consider using either open approach or the endoscopic petrosal approach. With endoscopic assisted petrosal approach, like what Professor Takio Goto is doing, or I can use the contralateral transmaxillary approach, the CTM approach to the petrous apex, which is actually more direct. Now, for posterior fossa lesions, for example, I did the cases which are shown in this craniopharyngioma at the brainstem. For that case, I just used the normal ordinary instruments, but to be honest, I'm in the process of developing some specialized instruments for transorbital surgery, which would be good to extend and expand the indications for endoscopic transorbital, especially in some fancy, unreachable, weird locations.
Thank you, Professor. Thank you.
Thank you.
Yes.
Thank you, Calvin. Any other questions from the audience?
Hui has raised his hand. Yes, Hui.
Yes. I have 2 questions to Professor Calvin. I feel great that I met you recently in Nagoya. My first question is, what is the structure inside the orbits that we had to pay special attention to because it is highly of injury, and before surgery, for the intra-orbital structure, what do you look at to analyze that is feasible to do this approach more efficiently?
Yes, okay. Again, excellent question. That would be very relevant, especially to orbital tumors. for orbital apex tumors, I always do a CT paranasal sinus together with a CT angiogram, which I will look very carefully at the relationship of the ophthalmic artery and the optic nerve and also the tumor itself. My approach would be trying to approach the surface of the tumor, which is farthest away from the ophthalmic artery first. So with a dissection of the tumor around, I would be able to eventually see the ophthalmic artery, which usually we can identify it under endoscope. And for these tumors, I also at the orbital apex, I also like to use a 30-degree endoscope, because with a 0-degree endoscope, it would be very difficult to view medially, especially when the ophthalmic artery is on the other side of the tumor. So, and then during the operation, it's very important to protect the ophthalmic artery. I use the cotinoids, the patties, to pack away the ophthalmic artery. And sometimes I also use ultrasound to identify the relationship between the tumor and the ophthalmic artery. And of course, need to preserve the ophthalmic artery at all costs. Sometimes for, actually a lot of times, for cavernous hemangiomas, we can see a very small vessel arising from probably the ophthalmic artery. It's very important to identify the stump and to cauterize it if it's identified. If not, then sometimes we need to keep a little bit of the tumor capsule behind in order not to injure the ophthalmic artery.
My second question is for the intracavernous lesions. So what do you have any algorithm or any type of tumor that you think that you have to choose the transcranial approach instead of a transorbital, or you can do a transorbital for everything?
Sorry, what kind of tumor were you referring to?
Yeah, you have to use transcranial instead of transorbital.
You mean for cavernous sinus tumors or for
Yeah,
which?
cavernous.
Okay.
Yeah, cavernous tumor.
All right. Okay. So if it's a pure lateral cavernous sinus tumors, then I think transorbital would be okay for most of the cases. Of course, that would mean the benign tumors. If it's malignant tumor, if it's proven to be malignant, then like for example carcinomas, then of course we need to do even a cavernous sinus eccenteration, then which means an FTOZ approach and with the ENT teams as well. Now, if we're talking about the usual like schwannomas, meningiomas, or lesions that we need to do biopsy sometimes at the lateral cavernous sinus. Well, I think nowadays I mostly use the transorbital route for lateral cavernous sinus lesions. However, if it's straddling the carotid artery, and if pre-op, when we do the CT or the MRI, we think it's very hard tumor, then we need to be cautious, especially if we want to do a total removal. Then we might need to revert back to transcranial approach, like using a Dolan or a Hakuba technique for the cavernous sinus lesion. But all in all, for lateral cavernous sinus lesions, I think transorbital approach, at least under my hands, would be quite comparable to transcranial for small to mid-sized lesions at the lateral cavernous sinus.
Thank you, Professor.
Thank you. If I may ask one question to Calvin. First of all, let me thank you for accepting our invitation to give us such a spectacular session. And regarding the surgery tones for beginners, where do you think we draw a line where you go on from the stage of early beginner novice to a expert? So what like is the number of cases that you would recommend?
I cannot give a definite number, but for everyone, but for me, I think I mastered most of the technique after an experience of like 20 cases. And my first, to be honest, I was quite picky in starting my first case. And actually, my friend Professor Park here, actually he did start earlier than me for transorbital. So he's one of the one of the few friends whom I consulted when I started my first case. I sent him I sent him the MRI and the patient details and asked for opinion. So I think this is very helpful to start because something quite new. And of course, the experienced neurosurgeons would always argue that this can be done by a very safe transcranial approach. So patient outcome is very important to start. You don't want to create extra complications for these patients. So for the basic indications, I would still suggest doing sphenoorbital meningiomas or mid-size trigeminal schwannomas. Large-size schwannomas is actually easier to do because the corridor is created, but you run risk of a CSF leak, and that's another problem as well. So once you get familiar and you get over the hurdle of 20 cases, then you should be fine. And by the way, I think navigation would be helpful. It's not agreed by everyone who do transorbital, but I still think it's quite helpful, especially for beginners.
Thank you very much. Another very interesting thing we noted that very less work of this approach has been done for aneurysms, which is much more common within the trajectory. If I remember right, the only case so far reported is from Professor Walter Sheen, but that patient was selected for a transorbital approach only because the patient had an irradiated skin and for squamous cell carcinoma, and that patient had a skin flap over the free pedicle flap over the chirion. So that's why they went into the transorbital approach. So, and recently I noted from Alberto Di Somna one article about reaching it transorbital approach to the vessel, the vascular area. So, why haven't you explored that area so far?
Yes. Again, to me, the patient's outcome is more important than my surgical excellence. So I think for aneurysms with the endovascular technique emerging, even for wide neck aneurysms, at least in Hong Kong, we have quite a good experience and a lot of tools that we can use. I know that may not be the case in other countries. And the vascular guys can do it as well. So we have to be even more cautious about our patient's outcome. Another problem with the endoscopic transorbital clipping is about the proximal control. For elective cases, it might be fine, like for unruptured MCA aneurysms, it might be fine. But if there is something happening during the operation with intra rupture, it will be a disaster. The space is very narrow, and to be honest, it would be even worse than transnasal. For endonasal, there is a paranasal sinus that the blood can drain out, so you can get a clear operative field. But for transorbital, it will be bleeding from the bottom to up. It's like filling up the surgical field very quickly, I can imagine. And that would be a disaster, and losing control in a ruptured aneurysm is the thing that we do not want at all during surgery. So that's why I still do not contemplate doing clipping via the endoscopic transorbital route. However, there's a very interesting indication nowadays, if we have some time. Raja, do we have some time? Yes?
Yeah, sure.
Yeah, so actually, I would like to invite Professor Park to share his experience with the intrinsic gliomas over the mesiotemporal lobe with endoscopic transorbital, which I still haven't tried.
Well, are we going to continue this webinar for another 2 hours?
Quick one.
Well, in case we'll invite
everyone
Professor
has 2
Park.
hours, yeah, I'm more than welcome to.
Well, we'll have a separate session for Professor Park this next month, but currently you can give a short overview.
Okay, I'll be more than welcome to do a presentation on that. Now, about the aneurysms, I know Disoma labeled it the hardest, the stage 5. But in my opinion, like Calvin said, with the aneurysms, it's not just about clipping. After you clipped it, you have to close the dura as well. But with a clip sticking out, I think it's a different issue with the tumors. And also with the clipping, is the angle of attack. With a craniotomy, it's easier to get wide angles of attack, but with a transorbital approach, you have somewhat of a limited angle of attack. So I think it'd be a completely different question with a clipping, with an aneurysm clipping. So I think we would really have to consult with a vascular surgeon, neuroneuro oncologist, about the stage 5 of the transorbital approach. But with a interaxial tumors, well, Disoma labeled it stage 4. I think it may not be as difficult as some of the benign tumors, but I don't know. I don't know why it's a stage 4, but it may be easier. I will certainly show you if you give me an opportunity to present on it. But I think anyone can do this as you gain experience with the approach, like Calvin said, maybe 10, 20 cases. You can start off with meningoceles, sphenoorbital meningiomas, and you can work your way up to do schwannomas, and then go over to interaxial tumors. I don't know about the aneurysms.
Thank you very much. So I think we had a very exhaustive session. Most of the things that we learned are relatively new. Thank you, Calvin, for sharing with us. We can end this session with the final remarks from Professor Hun Ho Park.
All right. Thank you, everyone, for participating in the webinar. Thank you, Calvin. I always admire your hard work, your passion with a transorbital approach. I would love to go to Hong Kong in November, and I would certainly like to congratulate you on opening your cadaver lab. I know how much work you put on, effort went in to doing that. So congratulations.
Thank you.
And see you soon.
Thank you for the kind words. Thank you. And see you soon.
Thank you very much. It was indeed a very wonderful session, and we're extremely indebted to both of you, Dr. Calvin and Dr. No Park, for taking out the time and support for the ACNS webinars. Now we'll close this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both speakers of today, Dr. Yoshitaka Nagashima and Dr. Calvin Mack, as well as the chairs, Professor Felipe Valdivia and Professor Hunho Park, for the time and support for the ACNS webinars. A very special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And as I want to mention to our viewers that this has been broadcasted on YouTube, WeChat and Zoom. And as of now, we have around 945 people who have logged in through all different channels. So we are extremely grateful to Professor Shubin. And also special thanks to my co-host, Dr. Hui Pham, who joined from Vietnam, Dr. Ben, who joined from Hong Kong. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.